Thank you for coming out, and I welcome you to our very first town hall meeting on infectious diseases. My name is John Crawford. I'm the Public Information Officer for the Office of Emergency Management here in Arlington County. Tonight, you will hear from a panel of experts who will give you a very comprehensive overview on how their departments and staff respond to and assist the public in cases of infectious diseases. You'll get a night of education. It'll be filled with expert advice while giving you all the opportunity to ask questions about infectious diseases and how it affects you, your family, and your community. But before we begin, I'd like to, first of all, introduce you to this expert panel that we have assembled here tonight. And to my immediate right is Dr. Rohit Modak. He's the Chief of Infectious Diseases at the Virginia Hospital Center. Dr. Ruben K. Varghese, Arlington County's Director of Public Health. Mr. Jack Brown, the Arlington County Director of the Office of Emergency Management. Arlington County Fire Chief Jim Schwartz. Arlington County Police Captain Michelle Nuneville. Dr. Brenda Wilkes, Assistant Superintendent of Student Services for Arlington Public Schools. Ms. Linda Erdos, Assistant Superintendent of School and Community Relations for Arlington Public Schools. Mr. Bob Smith, Risk Management Officer for the Arlington Public Schools. And again, Ms. Josie Sturman from WJLA, I expect her here any minute. I'd like to really thank this distinguished panel for coming out and volunteering their time tonight to educate all of us on infectious diseases. But a special thanks goes out to Mr. James Cole. He is the President and Chief Executive Officer here at the Virginia Hospital Center. Mr. Adrian Stanton, Vice President and Chief Marketing Officer for the Virginia Hospital Center, and especially Marianne Bouster, the Director of Corporate Communications here at VHC, who kind of helped me put this whole event together tonight. Also, I'd like to thank Nancy Leo. She is the manager. I think she's up in the booth there. She helped me put all this together as well. And last but not least, Laurie McArdle from Arlington Independent Media, AIM, and you'll see some cameras around the room. This will be a taped event tonight that will be aired on cable TV on Wednesday and Saturday this week and Wednesday and Saturday next week, and then it'll eventually get onto YouTube. So without any further ado, I'd like to introduce you once again to Dr. Modak. Dr. Modak.
Thank you, John. I really appreciate you organizing this very important event. I'm excited that we're able to come together, that you guys came, and we can talk about infectious diseases. We can talk about some of the threats that are coming to Arlington that may come and what our plans are and how we are going to protect everybody. I think it's a good idea to start with the general overview of infectious diseases. So, some questions that come up. What makes something infectious? What are the growing threats that we think are coming to our area or may already be here? And what can we do to protect ourselves? So it's simple to start with the definition. An infectious disease is a disease caused by entrance into the body of an organism. So a bacteria, a virus, a protozoa, a fungus. Very straightforward. I often walk into patients' rooms and I say, I'm Dr. Modak from Infectious Diseases, and they always take a step back in their bed. They always push away and say, oh my God. And a lot of them ask the question, are you infectious? Am I infectious? And really what I think they're trying to ask is, are they contagious? Do they have something that the public needs to worry about? So is infectious and contagious, are they interchangeable? Are all diseases that I study, are they all contagious? So when we first think about it, the answer is, well, yes, right? We have a common cold. That's an infectious disease. That spreads from person to person. Influenza does. And of course, Ebola, right? That's in our minds now all the time. That certainly goes from person to person. We'll have to be careful. But when we think about it further, well, wait, maybe not all infectious diseases are really spread from person to person directly. And that's important because when we talk about how are we preventing the spread of infectious diseases, maybe it's not so much, all right, let's find that person and control that infection within that person. Maybe it also relates to good sanitation, clean water supply. That can do a world of good in preventing the spread of infectious diseases. So when we think about what makes someone sick if we have these infectious diseases, well, first off, of course, it's the pathogen. That's what is that organism that's causing the problem. So for example, let's take a case of pink eye, which is caused by adenovirus, a virus. What happens if someone in your house gets pink eye? I'll tell you what happens. Everyone in the house gets pink eye. That's how this stuff spreads, right? Because it just takes very little virus particle to spread throughout the household. However, let's take the bacteria that we all have on our skin. And believe me, we're all covered in bacteria, and that's normal. We also have a lot of bacteria within our bodies, and that's normal. But you know what? That usually doesn't cause any problem. It lives there, and we don't get sick, and no one thinks that we have an infectious disease. A lot of it relates to the way we react to certain bacteria or certain organisms. And that's our own immunity or host defense, which is the medical term for it. So it's really a balance. It's that, here's the bacteria, for example, and here's our immune system. And we live in this perfect harmony, keeping us healthy. And if the bacteria overpopulate for any reason, if it becomes more virulent, if our immune system goes down, now there's a problem. And there can be an infection. And conversely, if let's say we're vaccinated and we have a better immunity against certain pathogens, now we're protected and we won't get sick. Another point is that the environment plays an important role both in our own defenses against infections and also in the way that these pathogens relate. So when we think about infectious diseases, we think about common things, right? Strep throat. Pneumonia, and yes, pneumonia is usually an infectious disease. It's a bacterial infection of the lungs. We think about MRSA and influenza or a yeast infection. These are all common infectious diseases. But when we think about outbreaks, oftentimes it's less common. So this is from the CDC. I just searched what were the recent outbreaks, and they had a beautiful website. Oftentimes it's from our food supply, right? So we talk about salmonella in sprouts. Think about things that, if there's any food that's been recalled. I remember I was sending back my almond butter I got from Trader Joe's because that was a recent recall. So it can certainly be in food supply. It can be in our medicines. So a little over a year ago, there was a huge outbreak, not in our area, luckily, but in the country, of fungal meningitis. So patients were being injected with steroid medicine, and that was contaminated with fungus, and it caused a lot of infections. But sometimes we don't know why these outbreaks occur. A year ago, there was an outbreak of meningitis in Princeton University. And we don't know what started it, but one person has it, and then it spreads and spreads and spreads. So what are some of the emerging threats that we foresee here in our community, in our state, even in our country? So first thing I think about are old diseases which seem to be coming back. In 2014, we've seen more measles in the United States than we've seen in the last 30 years. Why is this? Well, I don't know, but I think we do know, right? It's because some parents don't allow their kids to get vaccinated, unfortunately. We also see sometimes seasonal infections like influenza, which we see every year, but sometimes they occur in outbreaks, right? And we all remember 2009, H1N1 influenza. There was a big problem, right? It was swine flu, and everyone was scared, and I was scared, and we had patients in the hospital, and we had to deal with it. So every so often, viruses that we know, even in our communities, adapt and change. Sometimes there's new viruses. So MERS is Middle Eastern Respiratory Syndrome, and this was a new virus that was discovered in 2012, thought to start in Saudi Arabia, but has since spread across the globe. And of course, there are viruses which have been around, but have been limited to certain geographic areas that now have become global threats that everyone is a little nervous about. So why do these infectious diseases spread like this? And I think a good way to think about it is to think about it like a generation. So if I'm infected and I have 5 contacts, that's a second generation of infection. And each of those people have 5 contacts. And you can imagine it goes from first to second to third to fourth generation very, very quickly. Have one of those people now get in a car, travel to a new city, a new state, a new country, get into a plane. You could easily imagine how rapidly these infections spread. And that's one of the challenges with Ebola in Africa. How are we supposed to stop the spread of this infection? Another huge threat is not so much an organism, but it's a concept. And that's the concept of antibiotic resistance. So bacteria have been resistant to antibiotics since antibiotics were first discovered and invented. But recently, over the past 10, even 5 years, things have gotten a lot worse. There are more and more bacteria, viruses, say what you will, that don't respond to the medicines we have, and that's very scary. The CDC came out with a document last year outlining these threats, and it's very real. They estimate that every year there are over 2 million illnesses due to antibiotic resistance and over 23,000 deaths. So this is a huge problem. So there are a lot of threats out there. What can we do? So I'll tell you what we can do. It's actually not that complicated. Number one, we need to decrease our exposure to these pathogens. We need to prevent the emergence of resistant pathogens, and we need to increase our immunity. Okay, so how do we go about doing this? So it's the most basic thing we can do. We can wash our hands. That's going to be the best thing we can do to prevent infectious diseases. So do we wash our hands well in America? What do you think? Well, I think everyone in this room does, right? But what about everyone else? So how many times have you been in a bathroom and you've seen someone walk right in, use the facilities, and walk right out? But it's not just a bathroom. What about when someone's on a bus or in the metro or in an auditorium at Virginia Hospital Center, right? I hope we're all going home or going to the closest bathroom and washing our hands. It's scary, these kind of things that run around. So who needs to wash their hands? Well, of course, everyone in the hospital. Of course, our patients. But it's not just our patients. It's the medical staff. It's the physicians. It's the nurses. It's the volunteers. It's the visitors who walk in. But just like it is for healthcare people, it's also important for the community. When you're home, how are you going to prevent yourself from getting sick? You wash your hands. It's important for our children in the schools. I can't stress that enough, right? We all know kids have viruses. They all get sick. They all touch each other. Wash your hands, kids. Every day, my kids come home. I ask them, guys, did you wash your hands? Did you wash your hands? Finally, they know. They say, of course, Daddy. Who doesn't wash their hands anymore? Right? But they don't. Believe me, I catch them sometimes. It's the best thing you can do. Please wash your hands. How can we prevent resistance? So this actually goes, let's look at it from both angles. So from healthcare workers, what can we do? So we have an obligation to prescribe antibiotics only when they're needed. So that means if a patient comes to see me with a sniffle, I have to do my due diligence and not just give them a prescription because it's the easy thing to do. I have to use what I've learned in medical school and discuss this with the patient. And if they have a viral illness, then treat them with Tylenol or an antihistamine or chicken soup, right? I don't need to give an antibiotic. If I give an antibiotic, I have to make sure it's the right antibiotic. And if I have data that comes back later through lab tests, I need to change it. I need to be very particular about what I'm prescribing. If we have antibiotic resistance in our hospital, for example, okay, we need to make sure that that bacteria doesn't spread throughout the hospital. I need to isolate that patient. I'm not trying to label the patient, make that patient feel bad, but there's a public health responsibility. I need to make sure that that bacteria doesn't spread throughout my hospital to the immunosuppressed patients in the next room, We need to make sure we control that infection. What can patients do? Well, patients can make sure their doctors wash their hands. Now you may say, wait a minute, I can't ask my doctor to wash his or her hands when he comes into the room. Why not? Of course you can. I ask my doctor to do that. You have to do that. You want to stay healthy. but my doctor may not like it. Well, too bad. You're trying to stay healthy. Well, what if he's offended? Then it's time to find a new doctor. I mean, this is 2014. If people don't understand the importance of washing their hands, it's ridiculous. That's the most important thing you can do. What else can you guys do? You can take antibiotics as prescribed. So that means when you go to the doctor, have a discussion. If you're sick and the doctor and you together talk about your symptoms and decide that antibiotics are appropriate, then take what's prescribed. Don't take half the course because you're feeling better. Don't leave some for later because when you get sick again in a few months, oh, you can at least take a pill and maybe you'll feel better. That's what's causing resistance. We need to stop that. And finally, how can we increase our immune system, right? So every day I hear on Dr. Oz and in the newspaper, maybe it's vitamin D, maybe it's airborne supplements, maybe it's emergency that you get in Whole Foods. There's so many things that are out there. What's going to improve our immunity? So it sounds silly and it sounds basic, but healthy living. How do I know this? Because that's what science says. That's what we're here to do. We're promoting science, right? That there's been studies that if you eat a diet high in fruits and vegetables, you exercise right, you're going to have a better immune system. One thing I want to point out, adequate sleep. It matters. Getting 5 to 6 hours of sleep a night is not appropriate. It will affect your immune system. You need to sleep well. What else can you do? You can get vaccinated. Now that sounds silly, right? Of course, we all had our childhood vaccinations. Well, let's make sure our children are getting the vaccinations that are appropriate. Additionally, don't forget about adult vaccines, right? Are you due for a pneumonia shot? Did you get your seasonal influenza shot? These things are super important. That's how you're going to stay healthy through all these infectious diseases. Do what you know is right, and you'll make it out on the other side. I want to leave you with a video from the CDC about influenza vaccination.
It just hit so suddenly. It just took me by surprise.
We didn't think, oh no, there's a chance that she could get really sick and die.
We literally watched her dying. You know, her body was dying inside.
How does this happen? It's not supposed to. Here we had this beautiful, perfect, healthy baby boy, and all of a sudden, within a day, he's gone.
Influenza is a very serious disease. About 100 children die every year from influenza. Now that's a relatively small number, but every death from influenza is a tragedy, especially when we have a vaccine to prevent influenza.
I looked at Martin because he's old enough to make his own decisions and to tell me how he's feeling. And I looked at Martin and I said, Martin, what do you want to do? Do you want to go to the 3 o'clock appointment or do you want to go to the emergency room? And he says, no, Mom, I think I need to go to the emergency room. When I think of Martin, it always brings a smile to my face because he was such a good kid.
Really, kind of the whole day was just kind of like a long period of adjusting to what the truth was, which was that she wasn't going to survive that day.
She had the symptoms of a cold. It seemed, just runny nose and, your typical cold. But she couldn't shake it. And she had 4 days of fever. And I think that might have been our first indicator that something was a little more serious than just a cold.
The symptoms of influenza some of them are similar to the symptoms of the common cold, like a runny nose or stuffy nose, a cough, or congestion. But with influenza, you'll also see people feeling feverish, very tired, having muscle aches and headaches, things we don't usually see with the common cold. And while anyone can have influenza, it's more serious for certain groups of people and can lead to complications that are much more serious than the common cold.
The flu changed our lives. It took one of my children. The flu can kill your healthy children.
When Ian got the flu, he died. My other 2 boys who got vaccinated never had a symptom.
I could have got Emily a flu shot, and I should have got Emily a flu shot. I should have got all the kids flu shots.
Please get it. I don't want you sitting here having to talk about the loss of your child.
All right, so that's my presentation. I invite the panel to come back up, and I think we're going to hold questions until the end. Thank you very much.
Thank you very much, Doctor. Also, I'd like to reach out and give a warm welcome and thanks to our Arlington County Emergency Preparedness Advisory Commission, EPAC. We have some members here in the audience that joined us. And in the back, I'm honored to welcome County Board Member Libby Garvey. Thank you so much for coming. And now we will turn it over to Dr. Ruben Varghese. Doctor?
All right. I, too, have a small presentation, given that we're talking about facts about Ebola in the U.S., and then moving on to what public health does in a communicable disease effort. Obviously, I can support all the things that Dr. Modak talked about. Just given that we did use Ebola as kind of maybe the hook to have you all come in, some of the takeaway messages for us: there is no Ebola in the region as of today. You should educate yourself and others to prevent the spread of germs and panic. And there are many ways to protect yourself. And obviously, we recognize that Ebola is scary. However, there are things you can do to protect yourself, as Dr. Modak had talked about. Washing your hands. We have to remind people the real reason why is we have to get the germs off of our hands. We don't really think about it very often, but the reason why things like Ebola and other illnesses get to us is because don't do what I'm just doing on camera, folks, and those at home for the future. Don't touch your eyes, your nose, or your mouth. Those pink areas, the mucous membranes, are often the sources of where infection enters, okay? And so if you can get the germs off your hands, you can more freely do that. One reason why washing your hands is better than even antibacterial, hand sanitizer, that's the phrase. See, I don't even want to think about it. It just keeps it on your hand. It may be dead, but it's still on your hand. Hand washing, literally, the soap takes the fats off of the germs and gets them physically off your hands. That's really what you need to do. Even if you've done the hand sanitizer, the minute you have the opportunity to go and wash your hands, get the stuff off. And don't do this sort of hand washing because all you're doing is killing stuff on this side. You have germs on this side, so you have to really do that with water and with a hand sanitizer. Otherwise, you're really not helping yourself. Covering your cough, what you're really doing is preventing putting germs on your hand. If you do this, and if I cough in Dr. Modak's direction, he will not be, first of all, happy about it, and it's the wrong thing to do. Getting a flu shot, why does that protect against Ebola? It doesn't protect against Ebola, but what it does is you don't want to have Ebola and flu at this time of year. Can you imagine trying to survive both? It's not, either one it can be quite deadly. Having both is going to be next to impossible to have to fight. Avoiding contact with sick people. Well, that's the way you prevent yourself from getting ill. Sometimes that's not always possible in an office setting, so you still try to keep distances. If you can keep 3-foot distances, you're going to be able to reduce a lot of the contact that you're going to have that could make yourself ill. And obviously, you can help us by staying home when you're ill, because then you're not going to get anyone else ill, and you taking the time to recover yourself. Ebola is a reminder, it really has to be blood and body fluids that touch those mucous membranes or a cut in your skin. If those things aren't there, you're going to be able to protect yourself. And that's true for basically all sorts of germs as a general rule. If you protect yourself by covering any cuts and prevent yourself from getting anything on your mucous membranes, you're going to be able to prevent yourself from getting most illnesses. And remember, it's not spread through breathing, which is an important thing to remind people. So while it can spread, it takes some effort. So if I'm now going to make Dr. Modak the one that's got all these oozing bodily fluids, as long as he stays there and I'm sitting right here and he's not doing it in my direction or to Jack Brown's direction, we're fine. We're not going to get it because we're not touching our face, nose, mouth, and he's not spitting in our direction, and I'm not ducking and weaving. You know, I hopefully will do that. General rule, stay away from people who are oozing, kind of stay away. If you run to them, it's probably going to be someone like Chief Schwartz's folks, but they're usually wearing some protection at that time when they're running towards people with oozing. Parents also run towards oozing children. That's probably a good thing. So, so with that portion done, Josephine, could you pass out, and Sue, pass out the handout. The handout, one side has information on Ebola, but I wanted to discuss some of what we do in public health so you understand what we're doing when we're faced with a community threat of this individual infectious disease. Whether it's an outbreak or not, we are also interested in whether it's communicable. Will it communicate with as many other people, and we're trying to figure out who's at risk. So you get a copy of this. You don't have to be able to read all of this. By title, Approach to Communicable Diseases Threats. And at the very top it says observed greater than expected. One of the things that we're always trying to do is what we're seeing isn't what we expect. So for example, if there was a case of smallpox here in the room, well, what you want to know is you don't expect any smallpox cases anywhere in the world because it's been eradicated. One case of smallpox would not be something we'd expect. We want to investigate it. Okay. All right. Thank you. Likewise, when there's no flu, when we move towards flu season, there's going to be a change. But at the height of flu season, there may be an epidemic in the community, but we're not going to do necessarily anything other than recommend people to wash their hands, get their flu shot, and if necessary, those with flu will get antiviral medication from their physicians to help protect themselves. However, in a nursing home, where there should be good infection control practices, if there's flu and it's spreading throughout many individuals, that would be considered an outbreak because we're not expecting in a place with good infection control where there's more attention to that, we wouldn't want to see that. I would hope we wouldn't want to see that. So we're going to pay attention to that and say, that's not what we expect, therefore we should do more. So if we have a question that is more than we expect or unsure, we're going to investigate. What are we doing when we do that? The two things we look for are outcome and exposure. Obviously, exposure, what we're talking about is if you have germs, it'd be great to know that, like a Purdue turkey when I was growing up, apparently they had the thermometer that when it was done, it would pop up, right? I wish human beings had a little thermometer that went up that could tell me they've been infected. Whoever you believe in, I'm going to go, whoever designed me, I'm going to go, could you put that little device in? It would make my job so much easier, and probably Dr. Modak's as well. However, without that, it's rare unless Michelle Nunneville in the police department has intelligence that there's been a threat, in other words, a terrorist sort of plot. It's rare we know about germ exposure ahead of time. What do we learn first? We learn that there are symptoms or disease first. So people present, let's say, I pretend that only half of you got the handout and the handout happened to have norovirus on it. Okay? Following this exercise, you all go home and we hear that 50% of this room developed gastrointestinal symptoms. We may not know it's norovirus yet, but we would say, okay, there's a cluster who attended the exercise at Virginia Hospital Center, and those who went home with handouts seem to have more illness. We then would do testing to be able to maybe label it as norovirus, but we could say it's a cluster of GI illness, that sort of a thing. So that's often what we're going to do. Whether it's Ebola or norovirus, we use some of the same factors. How quickly we respond depends on some of the disease characteristics that Dr. Modak alluded to, things that are on this sheet. Incubation period. How long before the disease will develop? If it takes 20 days versus 2, obviously we're going to have more time to respond. It's not that we will wait till day 20 to try to do the investigation, but with resources we're going to decide how we're going to do that. We try to get as quickly a response as possible to match the incubation period of the situation. Because obviously there may be things when we get to countermeasures that we want to tell the public what they can do. So some of the terms, infectivity, it's basically how likely is a person going to develop infection, whereas pathogenicity is a fancy term for, okay, will it go on to disease within that person? And just because there's disease doesn't necessarily mean it's severe. Virulence is something that we'll look at also. Is it more deadly than some of the other versions? Route of spread, is it sexual transmission? Well, that's going to be a much smaller contact investigation because that's a less efficient way for disease to spread versus if it was flu that's person-to-person airborne, that can spread much more quickly. Ebola somewhere in between. You have to actually get in touch with that fluid, not just air. So we have to take those things into account when we do our public health investigations. Scope and scale of the population affected. If it's just this room versus all of Arlington County, obviously there are going to be differences in our response. When I've talked about risk communication, we need to tell a number of different groups about what they should expect, and it often changes over time. As you've even seen with the Ebola situation, there's initial information, and then as things develop, things change, and recommendations change. And so my staff and I are in often common contact with everyone on this panel because we have to deal with a lot of these issues for themselves as well as for you as the community and for businesses. So we often will work with the public at different times, healthcare establishments, including the hospital and nursing homes. When I put business here, that's not just talking about for-profit. That's any sort of organization that's doing something. We've gone to various businesses where they've had outbreaks, and we try to manage those things for them. And then obviously government activities. And so we come up with policies and procedures for infection control to help these organizations, and we've done that with Ebola as well. The reason why risk communication is important is how I think about hazard and how Dr. Modak thinks about hazard may be different from the way the public thinks about hazard. The risk from flu is greater than the risk from Ebola as a general rule for the U.S. However, if you see every year, there's been more attention on Ebola than there's been on flu. More people will die from flu in the United States than will die of Ebola, at least with present conditions. And yet, the concern in the public is more about Ebola than flu. And there's a formula that a risk communicator called Peter Sandman talks about: the risk equals hazard plus outrage. The experts believe in the hazard part. The non-experts, whoever they are, until their outrage about it matches the hazard, it's a different equation. So if you're more concerned about Ebola, it doesn't matter how much Dr. Modak and I keep telling the world that flu is more deadly here in Arlington County than Ebola. People, if they put Ebola with more outrage, their calculation of risk is higher. And part of the public health mission, as well as everyone else here, is we have to deal with the reality that sometimes there's a mismatch between what we think the hazard is, and Jack Brown deals with it all the time. How do you get people to prepare for the common things and have 3 days worth of food and water versus thinking about Ebola as the risk? So it's just one of the things that we all have to take into account. How do we deal with the real perception of risk and legitimize people's fears and still help them move forward? Because only as we go together as a community will we be able to do things. So just something for you to think about. Countermeasures, to wrap it up, fancy term for the things we try to do to control either exposure or outcome. Treatment, obviously, is going to be more on the outcome side, but with prevention and treatment, it's often the same things. Antibiotics can be used for both, antivirals, and supportive care. Prevention, as Dr. Modak already talked about, vaccines, often. Good hygiene, obviously, we're definitely always interested in that. And sometimes when it gets to things like Ebola, we then think about formal social distancing activities like quarantine and isolation, for which we have also been planning, hopefully never to use, but we have the abilities to pursue that. So with that, I'm going to sit back down, and I'm done.
Thank you, Dr. Varghese. And now I'd like to turn it over to Director Jack Brown of the Office of Emergency Management.
Thanks. Before I get into what the Office of Emergency Management does, I'd like to just ask a question to the audience here. How many people here are with the Emergency Preparedness Advisory Commission? How many folks here? Because I'm seeing a lot of familiar faces here. How about the Community Emergency Response Team, CERT? Some are members of both. How about the Medical Reserve Corps? How about the Volunteer Emergency Support Team? Okay. You folks, all of you, first off, I want to thank you for your service to our community, because every one of you out there helps us become better prepared. And that's really what the Office of Emergency Management is about. It's about making sure that the community is prepared, but also the county is prepared. OEM, we have two divisions, the Emergency Management Division, which does all the emergency preparedness work. We do a lot of community outreach. We work with businesses, we work with schools, we work with the whole community to try to get folks prepared. During an emergency, we operate the Emergency Operations Center, which stands up, mobilizes during emergencies, whether it's the pandemic flu or Ebola, a terrorist attack or earthquake or hurricane. We use what's called an all-hazards approach to emergency management here in the county. And it's pretty common throughout the country. That's the way most emergency management organizations operate. If you want to know who's in charge in Arlington County, it is the county manager. She is appointed by the county board as the chief administrative officer, and that's actually by Virginia state statute. The other thing we do in the Office of Emergency Management is we actually operate your 911 system. So when somebody's sick or injured, or your house is on fire, or you have some need for law enforcement or fire EMS, you call 911. It's our folks who answer the phone and dispatch the appropriate resources. So we're the initial intake for any emergency here in the county. One of the biggest things that we have to keep in mind is that it's not about OEM. If you want to equate us and our organization to kind of a stage play, we're more the directors and the producers, and it's folks like Chief Schwartz and Captain Nunneville who are the stars of the show, and Dr. Varghese and the docs and the nurses and the folks in the hospital who respond daily. We coordinate, we facilitate. We're the folks in the background. It's folks like the Community Emergency Response Team who are out there doing it when something bad happens. So that's really our role. We want everybody to be prepared. And if you look around, we've done a number of surveys over the years to kind of gauge community preparedness. And right after 9/11, we did a community survey. And it was conducted in 2002 and made public in early 2003. And we found that the level of preparedness generally in the Arlington community was actually pretty high. And why? 9/11. But then we did another survey 3 years later, and we found out that it was starting to go down and down and down. And it was very concerning in 2008 when we did the last survey, and we found that actually the level of preparedness, at least as gauged by folks that we asked, was kind of low. And we asked a lot of questions, why is that? Well, maybe some of it was the economy. Maybe it was because we were so far, past 9/11, people were kind of forgetting about it. But, we're still kind of in that ring, if you will. We're right next to the nation's capital. We still are, a target, if you will, for bad things to happen. But things happen all the time. We have weather events all the time. You go back to things like Snowmageddon or Ice-mageddon. Where people really do need to be prepared. And it's good folks like the CERT and the VEST and the Medical Reserve Corps and others who come out and really, answer the call when something bad happens, because Chief Schwartz and his folks and Captain Nunneville and her folks, they're really, really busy. So our resources are limited here in Arlington County. I know on any given day you can call 911 and get immediate police and fire assistance, but during a major emergency, we may not be able to get to you as quickly as we would like. So we really need folks to be prepared. And Dr. Varghese talked about the 3 days of food and water and meds and all those things. And if you go back to Snowmageddon, we actually told people, oh my gosh, you want to be prepared for at least a week or two. And there were some folks in the news media that actually took exception to that and said we were, over-dramatizing it. Well, a lot of people were snowed in for 2 weeks. So we really need you to take it to heart and to be prepared. We will come out to any organization, whether it's a civic association, schools, businesses. We do a lot of training and drills and exercises with the business community, particularly in the business improvement districts, to tabletop various situations. Unfortunately, we read in the news media about active shooters, and I know we're not here to talk so much about that, but we can help you with planning for virtually any event that might unfold. And we got a great staff in the Office of Emergency Management. Most of you probably know Deb Powers. I don't know if she ducked in behind the doors there, but she did our community outreach for many, many years. John Crawford is now doing it as our public information officer. So please get a hold of us. We're more than happy to come out and help any group become better prepared. So with that, I'm going to go ahead and turn it over to Chief Schwartz.
Thank you, Director Brown. And now I'd like to turn it over to our Fire Chief, Jim Schwartz.
Thank you, John. And let me also extend my thanks to everyone who's here this evening. A lot of very familiar faces. I very much appreciate everything you do for our community every day. And I know that each of those groups that Jack just mentioned that many of you are involved in, is but one small part that you play in this community. I know another part is that you are real champions for preparedness in this community, and we really do appreciate that because, as Jack indicates, when we're dealing with large-scale crisis, government isn't the only answer. It really is about community. It's about neighborhood preparedness. It's about individuals who are able to do for themselves and then for their nearest neighbors. That really does speak to an overall prepared community. So people always refer to us as the fire department, and I think everybody in this room knows that our mission, in fact, the predominant part of our mission actually is emergency medical services. About 64% of what we do is EMS every single day, and because of that, every person in the fire department is trained as an emergency medical provider, either at the emergency medical technician level or at the paramedic level. And we have I'm very proud to say, one of the very best EMS systems anywhere around. Many of you in the room also know that we operate in a very regionalized system so that our resources are extended into Alexandria and Fairfax as our nearest response partners, where for almost 40 years now we have operated a system that is based on who is closest to go to the emergency. That's why frequently you will find units from Alexandria and Fairfax in Arlington County, and if you happen to travel in those jurisdictions, you'll oftentimes see an Arlington response unit in those jurisdictions also. That extends our resources greatly, and it also provides for a much better system of response for our and our partner communities. It is important to note, however, that if we are dealing with a large-scale outbreak of the kinds of diseases that we are talking about tonight, those communities are likely to be as strapped for resources as we are. So the availability of that aid can be strained based on what kind of emergency, what kind of crisis that we are dealing with. Or if we were to get a really horrific outbreak of influenza, as we have seen in past years in this area, it may be as difficult to get resources from those jurisdictions as we do on a normal basis. So infectious diseases is something that we pay a lot of attention to. Why? In part because we are part of the healthcare system. When you think about it, that for many people, that the other end of that 911 call, that first access that they have to healthcare is through the fire department's resources to them in their time of need. The truth is, we're also interested in infectious diseases because we want to make sure we can keep our workforce adequately informed. This really goes to workforce resilience. And the reality is that if my workforce gets sick through something that they picked up either at home or on the job, we may not be able to provide all the services to this community that we are called on to do. So we spend a lot of time in partnership with Dr. Varghese and his staff. While we are not part of the public health system locally, there is a connection in that the Virginia Office of Emergency Medical Services that grants the certifications, the licensure, if you will, to all of our providers is part of state public health, the same organization that oversees the local organization that Dr. Varghese and his staff are part of. And moreover, as you heard him say in his comments earlier, there is a great deal of partnership here at the local level. I have a standing meeting with Dr. Varghese every month where we are talking about issues of intersection and preparedness between public health and the fire and EMS system here in the county. And as he also indicated, there are regular conversations, whether it's because something has cropped up acutely or because we are doing some planning for an event that we may see on the horizon. It really is a tremendous partnership that I think has influenced the region as a whole. We also have on our staff a full-time operational medical director, Dr. Reed Smith, who is an emergency room physician. He actually does a day a week here in this hospital, so he's part of this community, in their emergency care. But he also works for us on a full-time basis, and because our ability to deliver EMS is sometimes affected by our knowledge of infectious diseases. In addition to Dr. Varghese, Dr. Smith is constantly into the literature, looking at all of the information that's coming out of Centers for Disease Control so that we have the latest and most accurate information so that, again, we can prepare our workforce to provide the best service possible to you all. We do spend a lot of time thinking about how to protect ourselves. And I say that because there are times, depending on what the 911 call is for, that you will see us outfitted a little bit differently as we respond to a call than you might on a more routine basis. Our providers will wear gowns, they will wear masks, they will wear gloves. And for those occasions in which we believe the threat is higher, if we have information, as we have already run through in this community in what I've referred to as the best no-notice drill we've ever could have choreographed, that is the Pentagon pseudo-Ebola case from about a month and a half ago, we will upscale our protective measures, in ways that look more like a hazmat incident. Simply because we are trying not only to protect ourselves, but not be a vector for disease the way that Dr. Varghese was describing earlier. So we spend a lot of time on these issues. We spend a lot of time reinforcing for our workforce the kind of protective measures that they need to take. For 20 years, we have offered and gotten a pretty good turnout for our employees to get their own flu shots. As a matter of fact, for years, the Department of Human Services has provided flu shots to the fire department for no cost in return for us providing CPR instruction for major portions of DHS staff. Over the years, that has now grown that the entire workforce in Arlington County is offered a flu shot because it isn't just about emergency service providers, it's about the entire workforce minimizing the risk, not just to themselves and their families, but again, the community at large. So we have a very good system here where we pay a lot of attention to these issues. The different diseases, call for different measures, quite frankly, in various situations. But the reality is that when we respond to your call for 911 assistance, we don't know everything that we are responding to. We may be getting information from you, that may lead us in a certain direction. But the fact is that, our base protective measures and the steps we're going to take are around the same steps that we would take for flu, because that is the most prevalent thing in our community, especially at this time of year. And if it was something else, like Ebola, that obviously everybody has greater concerns about, again, because we have less information, less knowledge, less experience with it, those protective measures and the advice that we will give to you during those calls will pay the same dividends. So let me stop there and turn it over to Michelle, and I look forward to your questions following the last speaker. Thank you.
Thank you very much, Chief. Now I'd like to turn it over to Captain Michelle Nunaville of the Arlington Police Department.
Good evening. I'm going to be short and sweet because I guess I'm one of the superstars tonight, according to Mr. Brown. So, Police Department, you call us, we're there. We're not always so good about protecting ourselves, honestly. But we do have protective equipment that is issued to all of our officers, but as you all probably know, when we go into an emergency situation, the last thing we're thinking about is gloving up, masking up, or suiting up. And we rely a lot on the fire department, on public health, if there's a situation, and as Chief Schwartz said, we don't always know what we're going into. If we know that there's a situation, once we get in there, we certainly take precautionary measures to put on our protective equipment. We do have a safety officer. In fact, he's in the back for the police department, who monitors all of the incidences that occur, injuries to officers, if they're exposed to an infectious disease or bloodborne. And we have a procedure where we work very closely with public health and with Virginia Hospital Center in the event that we need the officers to be treated immediately. So, we do our best. We have policies and procedures in place. We, too, work with our communication center when we get a call, if there's any information they can provide, and that's not always possible. If we get to the scene before the fire department, EMS, we try to notify them and let them know what we have in the scene, and vice versa. So I say it takes a village, and for us it does, because we can't do this single-handedly. But we do our best with providing the officers the equipment to protect themselves, and certainly we encourage them not only to take their flu shot, but TB shot, HIV shots, all of those that'll be helpful to them when they're out on the street to protect themselves and, of course, to protect the community. And, we also know that police officers never come to work sick, but we try to encourage them if they are sick and not feeling well, to not come in. And we certainly we'll make sure that we have the coverage that we need. So that's it.
Thank you, Captain Nunaville. And now I'd like to introduce Dr. Brenda Wilkes, the Assistant Superintendent of Student Services for Arlington Public Schools.
Good evening, everyone, and I too will be short and sweet. I do want to tell you that our department, it's actually the Department of Student Services and Special Education, and we collaborate very closely with the Department of Health, with which I see Dr. Sam back there and Marion Harmon, who oversees school health. So we go into this armed with education from those who are the experts in the field, and through our collaboration we do many things, some of which include the first week of school, all staff are trained in preparing for issues like what we've discussed tonight, and how to not only protect our students but also protect themselves in the building. We work together to notify in collaboration with these two departments over here, which are going to hear from in just a few minutes. So it's a workforce together that gets the word out, but we also provide support for those who are affected by any kind of issues that might arise from any kind of diseases or pathogens that are out there. Specifically in my department, if we have students that are affected by an outbreak and are ill and absent from school for an extended period of time for medical reasons, we have homebound services that provide them access to a tutor, for lack of a better term, or a teacher that can help them carry on their studies while they're out of school, so that their falling behind is reduced to just about nothing. So that's real big in our department. For those of you who have experienced illness and students that have been severely ill and have recuperated or have passed on, you know, and as everyone else knows, the mental health impact that not only has on the families, but it has on the school staff who taught the kids, or if it were a staff member who worked side by side and shoulder to shoulder with that staff member. So our department is responsible through the access to school psychologists, and also in collaboration with the Department of Health in Arlington, in providing mental health support for those who are affected adversely by diseases and such. We have social workers that go to the homes of people who might have been affected by health issues, to make sure that the rest of the family is receiving support and provided access to information and services in the county if they're not able financially to sustain those services. So all in all, we like to call ourselves the social emotional support for everyone in the district, and I'm very proud of our department because we work so closely with our county agencies to provide such stellar service. And now the communication piece from Ms. Erdis, I guess.
Thank you, Dr. Wilkes. And now I'd like to introduce Ms. Linda Erdos. She's the Assistant Superintendent of School Services and Community Relations at Arlington Public Schools.
Thank you. I'll try to be brief because I know it's getting late. My department is responsible primarily for the communications and collaboration and operations piece of any kind of emergency or medical support. I think Arlington is very fortunate as a community and a school system that we have a model that is very different from most school systems in the country. If you go into a school system elsewhere in the state or in the country, you'll hear about them hiring nurses and hiring school resource officers. That is not the case here in Arlington, which makes it a whole lot better model. All of our school nurses are hired by the Arlington County Public Health Department. All of our school resource officers are hired by the Arlington County Police Department. That means that we are closely connected with, and our staff working in those functions have the most up-to-date resources and information through county resources. The public health, the school health nurses are being trained and informed and updated by public health, and their information is coming from CDC, from the Virginia Department of Health, which is a tremendous advance for us to keep us alert and up to date. In addition, we collaborate with them to the point that Marion Harmon, who's in the back, gets a daily report from our schools, even attendance. We monitor attendance so that we're watching and can see where spikes of attendance might be, where there could be a problem. Suddenly, 10% of the students are out ill. That's a good early alert system for them to start seeing what the issue is. My role, I work closely with most of the public health and public safety folks here in the county because we have a system called APS School Talk. And School Talk is an email, text mail, and voicemail communication system that we can target by school, by grade level, by many different ways, tied into our student information system so that when we find out that there's a case of chickenpox in a school, or when we find out that there's neurovirus, or when we find out whatever, we have the capability to instantly push out to parents in multiple languages through School Talk, as well as through backpack mail and other methods. We can push out the information to families of the fact that it's in that school community, what to look for, when they should keep their child home, and then we, as Dr. Varghese kept and Dr. Modak kept talking about washing hands, we can reinforce all of those standard wash your hands, cover your cough, stay home when you're ill kinds of messages to families. And then the last thing that we work closely with, we recognize our schools are more than just schools. During the daytime when kids are healthy and we want them to come in and learn, but we also understand as a community that if there's an emergency, our buildings and our facilities and our staff become a whole lot more than just schools. And we work closely with public health on planning if we had to do emergency immunizations or other kinds of emergency treatments, because we know that we are centers throughout the community where people can easily get to our buildings and have access to them in the case of an emergency. So I think it's a good collaboration and a good model for a community, and one that Arlington should be very proud with. And I'll let Bob wrap it up with the risk management.
Thank you, Ms. Erdos. And now, Mr. Bob Smith, the Risk Management Officer for the Arlington County Public Schools.
Thanks, John. So the benefits of being this close to the end is I get to say what they said. That sums up pretty much anything I had to say. But my title with APS is Risk Management Officer, and part of that is overseeing risk management and safety. Part of that role is coordinating emergency management operations in cooperation with our Assistant Superintendent for Administrative Services. And so we do the emergency planning, we do the emergency preparedness for schools, which in our case is based entirely on the planning and preparedness and all the efforts that are put in place by the Arlington County Office of Emergency Management. So it's like Linda said, our our officers in our schools are Arlington police officers, our nurses are Arlington nurses, our plans are Arlington emergency management plans. We have roughly 20-some thousand students and a little over 4,000 employees. So population-wise, we're bigger than some cities and counties across the country population-wise. When it comes to infectious diseases, we have the added challenge that 95% of our demographic are wonderful little germ incubators. And so we have to take that into account when we do a lot of our planning and preparedness efforts. So we include in our plans things like fires and fire drills and fire safeties. We plan for lockdown drills and secure the buildings. For whatever reason, in the last couple of years, we've added how to respond to earthquakes in Arlington for some reason. But we also have included in there pandemics, outbreaks, thanks to our Department of Health counterparts who've provided that information to us. And we do a lot of planning at the operational level and a lot of interacting with our school staffs on how to do a lot of the things that have already been mentioned today: hand washing, covering your mouth when you cough and sneeze. As a matter of fact, if you go into pretty much any elementary school in the county, in the restrooms you'll find the soap dispensers have a little sticker on it, and it's got the ABC's song spelled out on the sticker, and it tells the kids to sing the song twice while they're washing their hands, and that's how they'll know that they'll have their hands effectively washed. And so we do that on a day-to-day basis to prevent a lot of these little things that we've talked about, and hopefully that day-to-day planning and dealing with the little more common things like influenza help us when it comes to planning for things like Ebola and major outbreaks. So it is a cooperative effort both internally and externally. We rely on resources from the county. We rely on resources within schools. And so we've got a pretty good team and a pretty good process in place, I think.
Thank you, Bob. Our last panel guest was Miss Joyce Sturman from WJLA, and when waiting on, I guess she got tied up doing another event or story that she was possibly covering. So with that, that concludes our panel expert discussion, and now we will open it up to you, the audience, for any questions that you might have. We have some portable mics that are running around in the back of the room. So if you would just please raise your hand. If you have a question for any of the panel members, we'd be more than happy to answer it for you. No.
Who goes first? Ladies first?
Yeah, the microphone is tied into the camera.
Is it on? Yeah, I was, Jack, I was remembering one of your predecessors, not the one sitting next to you, telling me the thing that scared you the most was the big ice storm that took all the power lines down and the influenza outbreak that was like Spanish flu that spread so rapidly and was so hard to control. I did some reading on it recently. That's almost a really interesting story in of itself, how insidious it was. But if we had something that was highly contagious like that, as you ramp up the steps, what kind of steps do you do? Because it seems like to me the places where people congregate at schools, trains, buses, auditoriums are kind of the places. How do you control that? And do you have to declare emergency where the manager takes over some extra powers?
Yeah, just like in any emergency, we would likely, declare a local emergency, which gives the county manager and actually gives us certain authorities under state code. We would mobilize the public health operations center, would have the lead on something like that. But under our emergency operations plan, we kind of have three entities that work together. We have the emergency policy team, which Dr. Varghese sits on. Barbara Donnell, the county manager, chairs that. And policy level questions and decisions actually come from the emergency policy team. If you want to talk about like boots on the ground folks, that's the incident management team. In a fire situation or a law enforcement situation, it would be fire EMS out in the street. In a situation like this, it would actually be public health would coordinate that. And they would coordinate the execution of their duties in a unified manner with fire and police, and OEM would be there to assist them. But a huge factor in this is, what are we telling the public? Is there a need to do some type of social distancing? Are we going to be, enacting some type of a curfew or whatever we need to be doing? Those are decisions that are going to be made at the highest levels of county government. The board actually has a role in this too. And there is an annex to our emergency operations plan called the guide, for our elected officials, because they need to know what's going on, because they're being questioned by their constituents. What's going on? What's the game plan here? And we really want the board, and speaking through the chairperson of the board, to be that public face of reassurance and to have those talking points, which we will supply to them. So that's kind of how we mobilize. And then we have the Emergency Operations Center, which is the OEM staff, but also every department in the county has a role in the Emergency Operations Center in some fashion. And we break it down into what's called emergency support functions. And we're mobilized there. We can go virtual, and we've done it during snowstorms and other weather events where rather than crowding a whole bunch of people in a small room, if you've been to our EOC, you'll find that it's a pretty crowded place. We can actually do it remotely. We do conference calls. We use systems like Link. That's the county system that we use, and we bring things together. And we use a web-based program called Web EOC to track resource requests and what we're doing and so on and so forth. But that's kind of from a macro perspective how we mobilize. But those critical decisions are made in concert with the emergency policy team. And then the EOC is actually making sure that the affected departments and the community are getting the resources that they need. That's how we do that.
Ready for me? Is this on? Yes. My assumption is when someone presents with the symptoms of Ebola at a healthcare professional, that they are asking them if they have recently been to the affected countries. My question, I guess, is for Chief Schwartz. When our medics go out on a call, Arlington medics go out on a call, and people are presenting those symptoms, are we asking that question or relying on them to volunteer that information?
Right. Not only are we asking them when we arrive on the scene based on the information that we've been provided by the Emergency Communication Center, but based on what symptoms they are reporting when they dial 911, our emergency communicators in the ECC are also prompting some of those questions so that we get some leading information before we arrive on the incident scene. So if they're reporting symptoms that fall in line with the potential for Ebola, then that information, then that will drive the question, perhaps, or not perhaps, it will drive the question about travel history. And all of that information will be conveyed to us, not over the airways, but over our mobile data computers. I do just want to emphasize that while the question right now around travel is of vital importance, it is not lost on us that information may not be the only information that is an indicator of potential disease exposure. And I would point to the fact that we've had many people in this country that have gotten the disease in the country or have been exposed to other people. I shouldn't say many. We have, I think, a total of 11. But then we have dozens of others that have been proximate to people who were infected who never traveled to West Africa. So that piece of information is informative, but it is not declarative. So it is one piece of information that we will use to size up the situation and make the appropriate decisions.
This is for Dr. Modak. The CDC has recently done an oopsie on the efficacy of the current flu vaccination. Does that alert you to perhaps additional needs in the hospital?
So I don't know that the CDC made a mistake. I think what happened is
what they said was
that
we're
the
not
flu
sure
vaccine
that it's
this
going to
year
be
may not have
efficacious against
as
this
much
year's
coverage as
strain.
normal.
Yeah.
And I think it's a good point to make is that this happens every few years. And I think we usually expect to see the efficacy of the flu vaccine to be between 70 and 80%. And in a great year, maybe we're up to 85 or 90%. And a not so good year, we're maybe at about 50%, which is, I think, where may land this year. And I expect to see more flu. And I think, we're aware of that certainly in the hospital. Our primary care providers are going to be educated about that. Our emergency department is aware of that. And we're going to have a much lower threshold to test. I mean, we're going to test anyway. In flu season, it's always high on the radar, and we just expect to see more patients. But it would be the same plans that we always have for flu.
Thanks. I appreciate the information that's shared through APS Talk, but for those families that aren't, or those people who don't have children in APS, is there a Twitter account or some kind of social media that we should be following to learn more about emergencies or outbreaks in the community?
We can talk about the health part. As a general rule, we notify the appropriate audiences. So if it's a nursing home population, we're going to notify the residents of the nursing home and then say, for example, if they have a flu outbreak, we will recommend that they put signs up saying, what sort of protections that happen. But we don't necessarily say broadcasting to the world, because it's really, we're balancing that confidentiality need for those who are going to that nursing home or transfers from the hospital, say, to that. They're going to have it site-specific, because we want cooperation and collaboration. Not everyone wants to broadcast to the world their particular problems, and if they don't, they may actually report less if we start broadcasting to the world in that sense. But that is how we do it on the need of the potential folks coming in. So something like flu, a nursing home should be able to notify anyone coming in if there's a problem. Now, if it was a situation like an anthrax aerosolized attack, we would be working with our Office of Emergency Management to get that, and using the county infrastructure to get those messages out if we needed to do something on that level of prophylaxis for the community. Or if it was a pandemic flu, we would use the county infrastructure to talk about where people would get the vaccines and so on for that sort of protection. So the scale and scope of the situation dictates how we communicate. However, having said that, there are mechanisms within the county that you can sign up for that I'll turn to Jack Brown.
We have a number of communications mediums that we use for those kind of emergent situations. We use a system it's called Arlington Alert, and we ask you to sign up. That's an optional system. If you just go to our website, www.arlingtonva.us, and just look under emergencies, you'll see that. We also link all of our alerts through Twitter and Facebook, so the information is being pushed out there. We also have an AM radio station. During emergencies, we can broadcast over that, and we do. And that runs continuously with emergency preparedness messages, but then during specific incidents, we'll give more specific information out to the community. We're also working to get an FM station, very similar to the AM station, up and running on the FM side. So we as well as our website, and we work very closely with the county manager's office of communications to make sure that information that we're putting out is also on the county's website. So there's a lot of different communications mediums. Actually, after the derecho, we actually ended up, because people's power was out, we actually resorted to sending folks out, with flyers and going door to door, especially to some of our underserved communities out there, just to get information out. So we rely on everything from social media to traditional media. We work very closely with all the news stations. We have John Crawford, the PIO, to help us with all that. And quite frankly, it's the community volunteers that help us a lot as well. We've actually used the community emergency response team in some non-traditional roles, if you will. Not just doing emergency kind of work, but actually pushing information out. They're some of our best ambassadors.
How prepared are we in Arlington for the type of reaction from individuals who might not want to seek treatment early enough because they have other people at home to take care of, whether they are children or disabled parents, or what is done when people have fear of quarantine? By the way, you have not mentioned that word. I imagine it's probably not advisable to talk about it, but what do you do? How do you communicate to people so that their normal reticence is not there, and especially those individuals who might need treatment right away? How can the county help in those cases for alternative ways of taking care of the children and the disabled parents and so on?
Well, you may have come late, but I did actually use the term quarantine. I don't think of it as a bad word. We often do it voluntarily, but no, I understand the concern that both quarantine and isolation are very difficult topics for some communities. First, just define it for folks. Quarantine is for those who've been exposed but have not gone on to illness, but the fear is that they could, and if you keep them contained in an adequate space, they can then declare themselves or not, and then you're protecting others from them going on to illness. Isolation is for those who are sick. When we say stay home when you're ill, you're isolating yourself in that sense. Typically, those who are sick will want to seek care. So that's less likely to be a concern of getting them in. That still doesn't change some of the basic issues. And in fact, as we've been planning for quarantine and isolation, this is where the Public Health Division, being part of the larger Department of Human Services, really, which has the social services arms of the county and the state, really has been quite helpful. We've actually recently, with a particular type of illness not related to Ebola, for example, have discovered that, if someone needs to stay home with a child but they work overnight, well, there are actually daycare centers that are actually, they should be called night care centers, really, because they can provide parents with that sort of coverage, and we were able to, through that resource, connect the family so that the loved one could get the care they needed and the person at home could still actually go to work, and their child would not become, a CPS case, child protective case. So, in fact, it's trying to create those opportunities so that as we plan for the potential quarantine, say, of someone with Ebola, we've looked at that situation as well. If they have an adequate bathroom and bedroom for themselves, they don't have to leave their house. We'll work with them to help them understand how to interact with each other, but as I said, as long as they're not symptomatic, we're going to allow them to be at home and educate the people around them on how to protect themselves. Obviously, if they don't have that, we have plans in place to be able to quarantine individuals in appropriate places, and then also make sure that they can have the resources, or their family has the resources, to be able to survive. We're not talking about Ritz-Carlton conditions necessarily, but we're going to make sure that the basics, activities of daily living, are supported. So if they need rent support during that time, we have the mechanisms to do that. So we want to make sure that people are aware that they can get the care they need and protect the community, so that we've done what we need to keep that individual and their family safe, as well as the rest of the community. So we do have those abilities to do that. What we need is help sometimes advertising and letting people know that it is okay to come towards us. Anyone that we do hear about, we're going to help. It's when we don't hear about it, there's really nothing we can do till that occurs. And this is where we need your help to remind people that, in fact, we can be approached. We're not reporting people to other people. We want them to get the care that they need, and I believe that's true of everyone here.
Good evening. First, thank you to each of you for your service to this community, and really appreciate your time focusing on this issue. My question is about the early detection and surveillance of whether it's influenza or Ebola, and how maybe at the school, if there are a few cases of illness here, and maybe the fire department responds to a few incidents with influenza-like illness, for example, and maybe across the bridge in D.C. there are a few incidents, and in the hospital. Internationally, the World Health Organization has some systems and things like this, and nationally, CDC has FluView and FluMap, and I just don't know how that information actually gets up there. And so what I'm most curious about is how each organization is communicating as early as possible. Jack mentioned WebVOC. I don't know if that's a system that everyone's using, or how this information is shared, telephone calls, meetings, or is there a system to track these things so that everyone's antennas can go up and we can hit this thing before it gets bad? So that's my question, and I don't even know where to start. Is that Jack?
Let me take a stab at it, because it could be an infectious disease or a communicable disease. It could be anything else, and it really starts with the great relationships that we have in this region, in the National Capital Region, particularly here in Northern Virginia, but all over. And we use the Washington Metropolitan Council of Governments kind of as the hub. And there's committees for everything. There's a fire and EMS committee, there's an emergency management committee, there's a public health committee, and we do talk to each other. And we meet regularly, and when things kind of bubble up and we learn about situations that are kind of evolving, we convene conference calls. If it's a large-scale emergency, we actually have a regional emergency coordination plan which is executed. In fact, Barbara Donnellan, our county manager, is the chair of the Homeland Security Executive Committee for the entire National Capital Region, and she will convene a conference call with all the chief administrative officers and the leadership from the 2 states and the District of Columbia to look at it from the very highest levels as to what's going on. They have a 7-point checklist that they go through. But down at kind of the deck plate level, where Chief Schwartz and Captain Nonneville and Dr. Varghese and I are, we're talking to our colleagues, and we're also talking to each other. And we're tracking it through systems like WebEOC, but we're developing strategies locally, but also regionally to deal with whatever the emergency is. So those communications take place every day. We don't, I think Chief Schwartz mentioned it, the fire and EMS system here in Arlington truly is a regional system. Well, the information sharing is really a regional responsibility, and it's incumbent on all of us to be communicating with our partners throughout.
I would just add, setting aside for a minute, big dramatic disease outbreaks, we do this on a very routine basis. There probably is hardly. There certainly isn't a month that goes by, and probably not even a couple of weeks that goes by, that I don't get an email from Dr. Varghese about something that they're seeing in the community so that our providers can have a heads up on it. And also on a very routine basis, our providers, our responders will, with great regularity, run across things like foodborne illnesses, things like suspected meningitis cases. And from the incident scene, they are calling the public health duty officer. They are alerting the public health system to what they are seeing with that one case so that they can make a determination as to where they're going to concentrate their resources and follow up. If we believe that as an example, the foodborne illness, we may have some basic information about signs and symptoms. We may have gathered some other information just almost out of happenstance about where that person's been, and that information will be transferred over to public health so that they can do an appropriate follow-up. So it's, when it's big incidents, obviously there's a lot of things at work, but there's a lot of very, very small routine things that are happening on a daily basis, to keep things from getting big and dramatic.
I concur with Jack and Jim on this. What you may need to recognize happens in public health daily is when we were talking about the outcomes and exposures, there's a list of about 75 reportable illnesses in Virginia, and so you have all of the various providers who have to report this either directly or through lab reports, and that's what we have our staff who then prioritize that. And so we're looking to see, was it truly a one-off, or is there something greater? And so we have had the relationships with EMS as well. They're a provider. We have access to their run data. They've let us know when runs are going, when nursing homes are having the runs, so to speak. They've actually notified us, and a lot of other places have actually been quite surprised that our EMS are that diligent. They'll say, look, we've had 6 ambulance runs to this place in 24 hours, because not everyone will report. So we want to, well, they have to recognize it first. They may go, oh, it's just GI, it's GI. Okay, we're the ones who'll say, 6 GI cases in 24 hours, probably something we need to investigate. We'll take the information from wherever, and then we'll insert ourselves at that point. So that's often, it's the astute clinician, whether it's Dr. Modak or one of Jim's EMS folks or anyone in between, they'll go, something isn't right. If your expectation is nothing, and you suddenly see a spike, your observation is what you actually talk about. So you need to think about that. So it's really, as people are thinking about it, So we have those reportable illnesses, as well as we have the ESSENCE system, which is a syndromic surveillance tool that is both for the state as well as for the National Capital Region, where we look for various syndromes to look for the needle in the haystack, more for the rare event. Unfortunately, we still are always going to see the case first, most likely, because if we knew about it, why wouldn't we stop it? So we have to unfortunately realize that we can't prevent the initial few cases usually, but hopefully beyond that, we can start the containment and the prevention of future cases. And then, as Linda had talked about, we also have the enrollment data and the absentee data. This is where having the relationship with our schools is very critical, because illness actually often appears first among children. So if we have that information, we can predict, in a sense, what's going to happen next. It still doesn't mean we can stop it, but it helps us to know, okay, there are more kids out. Likely flu is starting to hit Arlington differently. It doesn't change our recommendation. Lots of people say, well, Dr. Varghese, tell us when flu's here, then I'll change my behavior. Wrong way of doing it, because flu comes sometime after October, okay? And someone in here could have flu right now, and because you can communicate it before you are really quite sick, you have to take the precautions ahead of time. This sort of I'll wait till you tell me still puts you at risk. And our belief is do the right things all the time to help not only yourself but the rest of the community. So it is taking a village to report these things. We've had people walk by certain facilities and saying they have a sign up that worries us. Please call us. We found out that they were kind of doing things on their own and had forgotten that they should let us know. So we go in and remind them and contain it. So we'll take all information at any time, and the public health staff are terrific, and we're on 24/7, so we can do those things.
Yeah, I had 2 quick questions, but I wanted to clarify a statement. Chief Schwartz, did you say there are 11 Ebola cases in the U.S.?
I think it's somewhere around that number of people who have been exposed, not have been exposed, but that have come into the country or been infected here.
Okay.
I think it's 11.
And that's available at the CDC website or something? Okay. My 2 quick questions are, 1, why is the influenza vaccine sometimes banned in other countries? And how long can Ebola survive, like, outside the body?
What was the first question again? Just
why is the flu vaccine sometimes banned? Like, it's been banned in Australia, I think 1 year. It's sometimes banned in Europe.
I'm not aware of widespread bans in Europe or in Australia about flu vaccine in general. There may be a particular strain that wasn't approved, but I'd have to see the information to comment on that. I otherwise defer to Dr. Modak if he has thoughts on that. On the Ebola itself, it really needs body fluid to survive, and even then it doesn't survive much longer. But if you had just a virus on the table, it should be at most minutes to hours based on the ambient temperature and so on. It really needs something to help keep it alive, but even if you've got the fluid there, it doesn't take more than a couple of days compared to norovirus, which can live on surfaces for up to 3 weeks. However, we're not going to be allowing people to get near. If we think there's an Ebola case, we're going to be then looking at the environments that they've been part of, and if there's confirmation, then we're going to be cleaning the surfaces in a certain way and making sure that there's no additional exposures to that fluid.
I've seen some information where they've said that in dried blood it can survive 3 to 4 days. Have you heard?
Thanks to all of you for your comments. I actually have a request, and I have a request for the people working for the Arlington County Schools and also for the Public Health, the Director of Public Health. My family moved from a country in West Africa called Ghana, not Guinea, in June of this year. And as we've learned the hard way, Americans don't have a great grasp of geography. So Ghana and Guinea sounds a lot the same. I have a high school student, she's a black African, is my daughter, who is enrolled in Arlington County Schools, Washington Lee. And then during the height of the kind of Ebola crisis, September and October, she got treated to comments like, as she's walking along in her class, kids going,
Ebola, Ebola. Some kids at high school football games coming up, do you have Ebola? All of this kind of thing. Even trying to get our dog the routine rabies vaccination during this period was kind of, having to explain Ghana is not Guinea. I mean, it got to be a lot. So I guess my request, I really appreciated that this information sheet had a map of Africa. That was very helpful. But I have a request to include just a little bit more information, like you don't need to suspect everyone from any African country. They may not have been there recently. Africa's a big continent, just to include that in your public health messages. And then I would especially ask the school system, because young people can be quite cruel, to be involved in some sort of public education efforts and be aware that there are African kids enrolled in the school system, and it's not just my daughter, she said, the other kids were also experiencing the same kind of treatment. And then just a reminder to our Director of Public Health that, for example, in Nigeria successfully contained and controlled an Ebola epidemic. This epidemic was a way to reinforce negative perceptions of Africa, and there were some positive stories that could have been told about how Nigerians cooperated, and it was the kind of basic policies of following up. So I'm just want to ask this as a request, just to be aware that we all have to kind of live with this for a long time afterwards. Thank you.
Good evening, thank you all. My question tonight is for public schools. It is, what kind of annual education do you provide for parents on what the relevant hazards are for this community and what the school's response would be if those hazards happened during school time, or if it weren't during school time and kids weren't able to go to school, what your response would be?
Okay, I'll try to take it in pieces. Training for our parents, we have a loosely organized support system for families called the Parent Academy. And we offer a lot of courses in the evenings and family enrichment on a lot of topics. Very often people from the county, Department of Human Services offer courses, and we work with them. So if there is a need that's identified, we can make that available. I know that there have been times where there have been questions by PTAs specifically about a specific issue, and then we'll work with the PTA to identify if it's somebody from Dr. Varghese or school health to go in and work with the community. Now give me the next step. That was part one.
I was asking about basic level of education of what the hazards are. So all parents, not just ones who select to take a course. For all of our parents, what education do we give them about what the hazards are, tornadoes, earthquakes, infectious diseases that they might encounter, and what the school system's response would be, how they would hear about it, what, if there's a tornado, what are their children doing, what should they be thinking about, that kind of thing.
We often do, and at one point I'll possibly let Bob jump in here too. We do a number of drills, as Bob mentioned, through the year: tornado, earthquake, shelter-in-place, lockdown drills, a whole series of drills. And very often schools will send home a message to parents saying, especially when it's younger children, and messages come home and it gets a little interpreted by children, to say to families, this is what we did today, this is why we're doing it. We want children to practice either lockdown or a fire drill or an evacuation drill of some sort, so that we know that practice in the classroom helps kids get better and helps all of us get better. There's information in our student handbook for families about the types of emergency management. situations we have and drills that we make. So we communicate through school talk, we communicate through the handbook. There's information on our emergency management section of the website, which tells the kinds of preparations that we do for that. Bob, do you want to add anything?
Sure. So kind of stepping outside of the infectious diseases realm and looking overall, like I said earlier, we do follow the County Office of Emergency Management's lead, and as they practice an all hazards preparedness, all hazards mitigation philosophy, we do as well. A lot of our processes and plans are in place, and they're there to address multiple types of emergencies. And I'll give you an example. We haven't had a significant loss of life from a fire in a school in the United States since 1958, but we still conduct annual, monthly fire drills. We teach the kids how to come out of a building in very systematic, organized as you can get elementary school kids' way. But we do that for more things than just fire drills or for fire emergencies. We'll do that for any emergency that would require the schools to be evacuated with little to no notice. We do the same thing. We practice lockdown drills for active shooter or active assailants. But we can use that for any type of emergency that would require containment of students with little to no notice. So we kind of look at things at a larger scale and where we can use different plans and policies. We make a lot of that available, like Linda said, in our handbooks that go out at the beginning of the year that are posted online. You can get those right off of our website. We have commonly asked questions about emergencies on our website that you go to. We're actually looking at it now to do some updates. And we've just recently gotten much bigger into social media. We've actually just launched an APS safety and security Twitter feed that we use to accomplish two goals. Primarily, we want to educate our community, our parents and our students and the families on how they can protect themselves because, like Jack mentioned earlier, a lot of emergency preparedness starts at home, and being able to protect your own family is a big step. But we also use it as a way to put out the message as to what we're doing to protect your kids while they're in our schools and the plans and the policies that we have in place to kind of take care of them. So it's a little bit of everything now. We do a little bit more every day to get the word out to what we're doing, but we're happy to share as much of it as we can.
And just to tag on to that, state code changed this year, and every school is required to have an emergency response plan, and the school emergency response plans, the overall plan, has to be reviewed in concert with the school superintendent, the police chief, the fire chief, and the emergency manager. And schools, Cynthia Johnson couldn't be here tonight, but she actually chairs a committee, an emergency preparedness committee, that's staffed by every agency I just talked about, plus the Department of Parks and Recreation, who share facilities with schools. And we reviewed those plans back in the summer, to make sure that they were all in line and we were coordinating information and information flow.
I was going to bring it back to the infectious disease realm, and APS does a tremendous partnership with school health in multiple mailings throughout the year. Obviously, people forget we have mandatory vaccination, for example, and so unless there's religious exemption or medical exemption, we won't have anyone start school without the appropriate vaccinations, and the school system does enforce that compared to some other places. It protects the children and our community. Likewise, when there's general policies about sending kids to school or when they should be staying home, and our school health staff, along with APS leadership, sends out that information reminding parents to keep kids home. One of the things you can help people to do is make sure that your neighbors are keeping their kids home. It's not always easy because they have the temptation sometimes saying, look, there's work and it's kind of tough. We've had, unfortunately, cases where kids are medicated before they show up, so they won't have the fever at 8 in the morning, but they have it at about 10, and it's not a good learning environment. It's not trying to blame as much as how do we change the behavior. And so these are things that you can help with. And then when we've had outbreaks, the school system has been very cooperative in getting education out about a particular information for that maybe classroom as well as for either that grade or that school, so that it's context appropriate. We don't want to inflame everyone because it just could be that something happened in a particular school, but we do pay attention, and we often write the letters jointly and send them out, either backpack or mailings. So that's the infectious disease side.
The other piece I want to add to that is that we have a school health advisory board that's made up of Arlington parents. And so they work closely out of our office to work on what they deem appropriate and how to educate parents on issues that come up, as well as, writing policies, correcting policies, updating, and keeping everything current. So it's got its own website. So again, it's the School Health Advisory Board. It's got a lot of information.
I recall that when we first started hearing about Ebola, the Texas case, between the media and politicians and the internet, there was an awful lot of misinformation floating about. Does the county have any program for an active program to monitor and control rumors?
Office of Rumor Control. Yes. While I don't head up the Office of Rumor Control, we definitely get our share of rumors. We will try to, depending on what the situation is, try to investigate what the origins are and try to correct it, but it depends on what it is and where it's coming from. That's the best I can do on the infectious disease side, especially in our media market, depending on how many rumors are. Sometimes the best way is when the media comes to us to then say, put it in proper perspective, but we don't always have that voice until someone shows up.
Excuse me if somebody asked this question already. I was out trying to remember how to sing my ABCs. But there was some information that the Fire Chief Schwartz alluded to about the pseudo-Ebola case. I believe there was a good amount of misinformation about the handling of that and the hospital's readiness. And I'd kind of like to give our hospital host a chance to kind of explain what happened and how you guys are handling the new CDC protocols and your readiness.
So let me tackle this second part first, and that is that Virginia Hospital Center is prepared to take care of an Ebola patient, as is the mandate, as every hospital should be across the country. I keep telling everyone here, and everyone's very responsive in the hospital, that, to be honest, we don't know what's going to happen. If we do get a patient, will they be transferred to UVA or VCU or a local facility or Emory? We don't know, and we need to be prepared to take care of a patient with Ebola. We have appropriate personal protective equipment, PPE. Our staff is being trained and retrained every week on how to use this equipment, how to care for an Ebola patient, how to adequately not just care for the patient, but protect ourselves, our staff, our patients, and our visitors, so we can do that effectively. So I feel very confident in this hospital's ability to do so. In terms of that day and what happened, to be honest, there was information coming in very quickly, as I'm sure you knew. There was a patient at the Pentagon who seemed to have Ebola. And as more and more information came out, maybe she was in Sierra Leone. No, wait a minute, maybe she was in Liberia. No, wait a minute, maybe she wasn't there. Obviously, at the end of the day, it turned out she did not have Ebola. With all of that misinformation, she was in an ambulance that ended up at Fairfax Hospital. And I don't know what happened on that day. I do know that we were prepared. If she came to our hospital, that day, I'll tell you, I was in the emergency room talking to the nurses, watching them wear their PPE to effectively protect themselves should that patient come in.
Okay. I'm fascinated by the social norm in Japan, how a lot of folks wear their N95 surgical dust masks. And I'm curious, I can't help but think on the metro to work every day, if there were a release of some sort in those tunnels and you're stuck in a train, should we all be carrying around these N95 dust masks? And at what point do we start wearing them if there are infectious diseases? Is there a level where we say, okay, we're code orange now, let's go on, and I'll try to buy these dust masks and put them on? Oh, I have one.
I think you've hit on the social norms and what's acceptable in this community. I've also talked to you about the risk equals hazard plus outrage, it really is going to be, those things are different for each community, and I think in this case, this is the U.S. It's a decision that I think we're different in this way, or the Japanese are different, so there's nothing stopping you if that's what you would really like to do. However, the true risk from infectious disease can be managed. Yes, there are some risks. If you believe the risk is beyond a certain level, obviously you should take the protection you need to take. But for infectious disease, there are common procedures that can reduce your risk. So if you can keep certain distances, you're going to reduce your risk. If you get the flu shot, you can still travel on the metro, but you're going to be less likely to get the flu. But remember, the flu shot is not 100% even in a good flu vaccine match year. So, but you may have reduced risk. So I think you're going to have to balance and decide what you believe you'd like to do as a community and individually about risk. But there are ways to keep ourselves reasonably very healthy, reducing the risk, and preserving the way we normally do in maintaining our level of resilience.
Just to set a little bit of context, as pre-hospital care providers, we more frequently put the mask on the sick person because that's what will restrict their ability, okay, to project their infection. And so you could be wearing that mask, as Dr. Varghese says, on the metro, and somebody who's not wearing one sneezes on you, and you know, without those precautions, you know, they figured out a way around that mask.
Certain protections may make you feel like you're more protected, and it may reduce your actual preparation. Because as Chief Schwartz just said, if you just got sneezed on that mask, you touch that mask with your bare hand and you forget to wash your hands, guess what? You can infect yourself. So unless we make everyone wear it, and how many of you have ever worn a mask for more than an hour? It's not fun.
I want to thank you all for donating your time tonight and having this very useful forum. I'm an emergency planner for a large private sector employer in Arlington, and I feel very confident with our ability to deal with the potential Ebola case should we ever get it. One of the things we're wrestling with, though, is we feel confident in the medical community's ability to handle the case, and I think there were enough lessons learned after the Dallas healthcare workers got it that wouldn't happen here, would be less likely to happen here. As an employer, however, we wonder if we find out that we have a staff member, and I realize the risk is extremely low with the current conditions in the country. If we have a staff member that, say, volunteers with Doctors Without Borders, comes back, is diagnosed with Ebola, how do we restrict the risk to other employees? We know that for other communicable diseases, like say tuberculosis, we would work with the Department of Health and do contact tracing and things like that. But for, you know, the day that we find out someone has Ebola and was in our office, before everyone freaks out, what should we do from a reasonable, perspective?
Well, this is, I was wondering when the question would finally come so we could talk about what we're presently doing. As part of the larger effort in the nation, first of all, there's screening going on at 5 of the nation's airports for where any person that's traveling from an Ebola-affected nation will pass through. In which, if you realize, before they leave the country of origin, they're being screened. And if they have any symptoms, they won't be allowed at that point to get on. Then, when they stop now for Dulles, the airport or nation they stop in, they'll be in Brussels before they leave for Dulles, they're screened again. Finally, they're screened again at Dulles. So first of all, there are those layers to try to reduce anyone with symptoms from coming in. And unfortunately, if it's symptoms and you come from one of those Ebola-affected areas, the presumption is going to be Ebola till proven otherwise. However, the risk still is for something other than Ebola. Malaria, the recent case in Boston, malaria is one of the things, and now with flu season is still more likely. So, and we're working with the CDC. Anyone who's identified as a traveler, they notify the health department if they've had active travel but don't have symptoms. And we're presently monitoring people in Arlington as our people across the nation and health departments to monitor them. They're allowed to actually go to work. They're the low, but you can't say zero risk, and no one has gone on to disease. But we're working with those employees. Obviously, if you've got concerns, this is where if we thought there was an exposure, as we were talking about previously, we will work with your establishment to identify who may be at risk for that exposure. But remember, just because they may have been exposed does not mean they're actually going to go on. We're going to do the interviews to find out what that exposure risk means. Sitting in a room with someone is not going to be the issue. Did they really come in contact with secretions? We'll take an abundance of caution and probably add them to at least the low but no risk category initially. We have to first confirm the Ebola diagnosis. If it doesn't turn out to be Ebola, first of all, then we're going to stand down and we're going to know those results in under 24 hours, usually under 12. So it depends on interviewing the person and finding out what their true risks are. But if they really were Doctors Without Borders, they normally already have protocols in place to say, do the self-monitoring and identifying with the State Department or the CDC to let us know what further things have happened. And we've had people call us, if it's gone through the system, to actually identify themselves. So we've actually been very fortunate, and we recently had a case where someone was traveling from another state. They ask us, will we take it over or are they going to continue? So they've worked through those things. Obviously, there's always the potential for an error, but if you think that there's an issue, don't hesitate to call us, and we can talk, our staff can talk and figure out, is this a situation we need to even be remotely worried about, so we can wrap our arms around it and help you with it.
I think that concludes our first annual town hall meeting. Thank you so much, everybody, for coming out. Thank you, AIM, Laurie, and the crew for filming this. Again, it will be aired on Wednesday and Saturday, and again next week, Wednesday and Saturday, and it'll go on the YouTube. Thanks for our panel of experts and their insight into infectious diseases, and I really thank you all for coming out tonight.